Perfect. Thank you so much for that kind introduction, Emma. So I'm from the University of Bristol, and today in this webinar, I'll be talking about 2 research studies which we conducted at the University of Bristol, where we looked at the mental health of children and young people growing up in care in England. Before I talk about the research, I would like to acknowledge the brilliant research team that I worked with, and also the advisory group where we had participation from these organizations that are named on the screen. We also had advice from a brilliant group of care experienced young people who helped us to create a suitable survey for children and young people in care. This was funded by 2 grants from the Economic and Social Research Council, the ESRC, and we had ethics approval from the Faculty of Sciences and Social Sciences and Law Ethics Committee at the University of Bristol. We also had approval from the Association of Directors of Children's Services, as we were working with several local authorities for this research. So now to get to the presentation itself. So I will talk a little bit about the context of this research, what we did, some of the findings, and what the implications are for policy and practice. This research was conducted at a time where there are a rising number of children in care in England. At the last count, there were more than 80,000 children growing up in care. That's the orange line here, and as you can see, this is a growing concern, and the numbers are rising year on year. And why that is a concern is because of the reasons that they come into care. The majority of children coming into care are taken into the state care because of abuse or neglect, so severe maltreatment, although there are other reasons as well. And we know, apart from this maltreatment, some of these children, or the majority of these children, have poverty, disadvantage, they also have deprivation, which might also be exacerbated by their exposure to things like domestic violence, parental criminality and imprisonment of parents, concerns regarding parental mental health, and also substances, exposure to drugs or alcohol in utero or postnatally. And we know that all of these adversities have an impact on children's mental health and other developmental outcomes. It can lead to emotional dysregulation, psychopathology, and also have a negative impact on their psychological, emotional, social, and physical development in childhood, and also well beyond into their adulthood. Now, the expectation is, therefore, that when the children are then coming into care, that it would be better for them. Their developmental outcomes then should be better once they come into care. And it's written in the law as well. The Children Act 1989 states that it's the duty of the state to safeguard and promote the welfare of children, and that it should facilitate their recovery from these previous adverse experiences, and that it should promote their physical, emotional, and mental health. Does it actually happen? This is data from last year. These are the number of placements that children had last year. The majority, around 2/3, had only 1 placement. So they were in one foster care or another placement in care. But 1/3 of children had 2 or more placements in the care system. 1 in 10 children had 3 or more placements. Now, when we call it a placement, it sounds quite inanimate. But what it means is a placement change usually means their home changes, their carer changes, their neighborhood might change, their school might change, their friendships might change. So this in itself becomes an adverse outcome for children in care as well. So this is again a continuous picture which we haven't addressed, and that's something that hasn't changed much across the years. And this statistic, that around 40 to 50% of children and young people might have a diagnosable mental health condition as they grow up in care, is again something that hasn't changed much over the years. Compared to children in the general population, this is significantly high. So, what do we then need to do to address this very high mental health concern for children in the care system? We need to know what actually happens to their mental health as they enter the care. If the purpose of taking children into care is to improve their outcomes, we should then see stability of mental health as they enter the system, or we should see improvement. Does it actually happen? Or do we see decrease in their mental well-being? Or do we see no change at all? At the time when we did this research study, there was no national level evidence on how these mental health patterns changed over time. And there were no observational studies which looked at this. So one of the purposes was to see what are the patterns of mental health as children stay on in long-term care in the system. And do these patterns change for different groups of children? We wanted to know this. And also we know developmentally, everything in a child's developmental context impacts a child's developmental outcomes, including their mental health. So their placements, their schools, social work, neighborhoods, their behaviors, everything impacts. But there were no studies that have been done on children in care, which have looked at all of these factors at once to see what actually then impacts the mental health of children and influences them the most if you were to consider the whole developmental context at once. We wanted to look at that. And because we were doing these research studies during the pandemic, we could also see what the impact of the COVID-19 pandemic was for children in state care. So how did we do this? First, we accessed national data held by the Department for Education, because every local authority in England, there's an annual statutory requirement that they should return data to the Department for Education on children in care. Their placements, their characteristics, their legal statuses, why their placement changes, and also this is linked to their educational outcomes to the National Pupil Database. So we had access to these national level data sets. And one thing that's included in this national level data is also the screening test for mental health every year. So we had annual mental health data for children in this national data as well. But national data does not hold much contextual information. It also doesn't hold any information on children's own feelings or views about being in care. So to address that, we carried out a survey of children in care, one in 2020 and one in 2021. We also spoke to local authority professionals to understand more about how do they use the data that they collect annually to actually provide mental health services for children in care. I will be talking about the first two sets of these results rather than the last survey of professionals today. The main outcome measure that we used across our two research studies was the Strength and Difficulties Questionnaire. Now, this is not a diagnostic tool, it's a screening test to indicate whether a child might need mental health intervention. And the main reason that we used this was, this is what's used nationally for the statutory data collection. It's a statutory requirement that every child who's been in care for at least 1 year and who's between the ages of 4 and 16 gets an annual screening on the Strength and Difficulties Questionnaire, and that this data is returned to the Department for Education. So we use the same data, same questionnaire in our surveys as well. The Strength and Difficulties Questionnaire has 5 subscales. It looks at emotional difficulties, whether children have conduct difficulties, whether they have hyperactivity or inattention difficulties, whether they have difficulties with peers, and it also tracks their pro-social behaviors. Now, the total difficulty score, which is returned to the Department for Education, is the 4 subscales at the top. It sums up the 4 subscales and creates a total score and gives a total difficulty score. That's what we used. And these are what the national norms look like for the total difficulty score. The majority of children in the general population are in the normal range. 82% have very low scores on the SDQ. Around 8% are in the borderline range, and around 10% are in the cause for concern range. So these are the national norms that we compared the children in care with when we were assessing their mental health. So just to talk a little bit about the National Administrative Data Analysis, like I said, we had access to the children in care data and the linked education data. We wanted to track their mental health for at least 5 years. So they had to be in care for at least 5 years to be in the sample. We also thought of care as an intervention in the lives of these children. So we excluded any child who were going in and out of care. So any child who's been in care for at least 5 consecutive years were included. And we also checked that we had at least 3 scores of the SDQ, just so we can see the pattern of change across time when we do the statistical modeling. And in terms of psychology and development, we know that developmental stage impacts the developmental outcomes of children. So when we looked at the data, we considered it to be the primary school age and the secondary school age. So we divided the data to look at whether developmentally, whether the patterns of mental health change are any different. But we also added another group, the school transition group, because our hypothesis was that going from primary to secondary school is again another major change for children in care, and it might then impact their mental health. So we looked at the group of children who are in the school transition age as well. And we use something called latent class growth analysis, which are advanced statistical models, which looks at individual patterns and then groups them into, depending on the similarities of those patterns. Okay, so what came up in our analysis? You can see here that this is the primary school age cohort. They were aged 7 years at the beginning of the observation period, and they were 11 years at the end of the observation period. And you can see there were 4 distinct patterns that we saw for primary school children. Some stayed in the low range, some stayed in the average range, but a large group of children, 48% of them, stayed in the cause for concern range across time. Now, this has implications for mental health support and also tracking mental health support very early on during primary school as well. Here, you can see that 48% are in the cause for concern range. Yeah. This is the school transition age. There were 4 distinct patterns again, but here you can see for 2 groups of children, for one group, their mental health decreased over time. Concerns decreased over time. And for one group of children, the mental health concerns increased over time. So you can see that this transition period for some children were positive, but for some children, it had a negative impact, which perhaps puts a responsibility for the social workers or the virtual school heads to be more aware of children's mental health as they move from primary to secondary school. This is the secondary school age. We found 5 distinct patterns here. And the biggest finding here was the number of children or the proportion of children who were in the cause for concern range at the end of the observation period. So they were 16 years at the end of the observation period. There were a quarter of children who were in the cause for concern. If you remember, it was 48% in the primary school group. So it seems to indicate that for older children, the concerns do decrease as they age in care. It might be that they're getting the support that they need at this time, and maybe that's what's reflected here. So the main thing that the national analysis of data, the analysis of national data told us was that all children do not have similar patterns of mental health across time. And we should be looking at children's mental health across time rather than only cross-sectionally every year, which is what we do at the moment. It should be tracked individually across time to see what sort of pattern they are showing, so that if the children are in those high-risk categories, intervention can be given at the earliest possible opportunity. But as I mentioned, the national data do not have much contextual information, so we wanted to carry out a survey of children in care to do just that, to collect data on the children's developmental context. Why is it important to consider this? Because everything in a child's context, the developmental context, impacts their development. Now, this is a theory that was proposed by someone called Bronfman-Brenner a long time ago, but it still stands. What this says is the child is here, for example, in the middle here. They bring their own individual characteristics and their genetics into play. And then you have the microsystem. So these are the direct environments that children interact with every day. For example, their foster home. It might be their school. It might be their neighborhood. It could be the nursery. All of those are things that children have direct involvement with and has an impact on them directly. But these, again, don't happen in silos. They also interact with each other. For example, if a child was bullied at school, it might impact their behavior at home. If a child was maltreated at home, it might impact their educational outcomes at school. So they interact as well. And then you have the exosystem, is what they call, where there are people who are in the child's microsystem who are here, for example, carers' workplace. How does that impact child's outcomes, for example? Do they have parental leave? Do they have sick leave? That can directly impact children's outcomes as well. Then you have the state, for example, the law, the national context, the child welfare system, all. And for most children, it is quite removed, the child welfare system. They're not in play in their microsystems. And all of these change over time. Children grow over time, and they interact differently over time. The context change over time. So all of these change. And we wanted to say how all of these interact to impact the mental health of children. And one thing that's different for children in care is this child welfare system. For children in care, the child welfare system is right there in their microsystem because of the social work involvement in their lives. So to consider all of these in our survey, we, as well as collecting data on the mental health of children, we collected data on their characteristics, things about their placement, about their school, about the social work support they had, about their friends, health and well-being and other behaviors, and also their relationships across all of these developmental contexts. It was created with input from a group of care-experienced young people, and we sent the survey to the children and young people via the local authorities. It was linked to children. We did not have any personal data like names of children, but it was linked to their administrative number on the survey so that if there were any safeguarding concerns raised, we could tell the social work team and they could raise it at that point. Every child was given a gift voucher. So who participated? These children were all 11 to 18 years of age and were in care for at least 1 year. We carried out the survey twice, one in 2020 and one in 2021. And then in the first wave of the survey, we had 930 children responding to the survey. And in the second wave, we had 688 children, which are really good numbers for statistical analysis. Now, before I talk about what influences the mental health of children, I thought it'll be really nice to show you what they felt about being in care. The majority of children, the two bars represent the two waves of data, the purple and the other color. I don't know what to call that color, pink. As you can see, the majority felt safe in their placement. They thought they can be themselves. They felt safe in the placements where they were living in, and they were happy. But as you can see, these two categories here at the bottom needs perhaps more improvement. Whether they thought their views were listened to when others made decisions about them, and whether they thought whether their life was better now that they're in care. Some just didn't believe that their life was better than it was before. And I think perhaps that needs more work and improvement there. So this is the mental health data. This is the SDQ total difficulty score, and we compared it with the general population data. A survey was carried out at a similar time as us through the Understanding Society survey, where they carried out a survey of children and young people in the general population. So we had general population comparators for a similar period. So children in care were significantly more likely to have a cause for concern score compared to children in the general population. Now, I should present this slide with a caveat as well. As I mentioned, the service was sent via the local authorities to children and young people, and it was an online survey. So we did tell the local authorities if they had any concerns about the children's well-being, please do not send this survey to them because it's not appropriate to do so. So it is possible, and it was also opt-in. There was absolutely no requirement that the children completed this. So it is possible that this is an underestimation, but still it shows that the children in care are significantly much more likely to need mental health intervention than children in the general population. It was very similar for the 4 subscales where the total difficulty score come from. You can see the trend again, very similar here. The general population norms are again at the top of every chart. And you can see that they were significantly more likely to have more emotional difficulties, more behavioral difficulties, more attentional and hyperactive difficulties, and also difficulties with peers. And one of the things that we saw as quite stark was this one here about attention and hyperactivity. As you can see, it is quite high. The proportion of children who have high scores in this subscale. And that's something that we are looking into now as to why this might be the case. We also asked about self-harm. 1 in 5 children in both the surveys, 1 in 5 children said that they self-harmed before and they were self-harming during the pandemic as well. This has again implications for asking children about their well-being, and what came across in the survey was children were likely to respond accurately if they are asked the question, and this has implications for practice as well, whether we are asking the right questions from the children. We also asked children about their own assessment of their mental health and whether they had access to mental health support. Now, this is before we talk about the factors that influence. So this is children's own assessment of their need for mental health support. We asked them, did you ever need support for your mental health? 39% of children in wave 1 and 35% of children in wave 2 said, yes, we needed support for our mental health at some point in my life. And we asked them, who did you ask for support? Where did you get that support from? And this is what they said. They could tick as many boxes as possible in this list. And you can see that they got their support from their carers, counselors or therapists, school, social workers, friends, parents, and also sometimes school nurses as well. There was around 1 in 10 had support from the health system, practitioners from the health system. We asked them, did your support change during the pandemic? Did you see any change? 75% said that it was either less often than before or that they no longer had access to support. Now, this is concerning given the high prevalence of mental health need, that these support levels actually decreased for children in care during the pandemic. What we do not know at the moment is whether these levels have now increased back to what they should be, because we did not carry out another survey after the pandemic. We then asked them, did you need any mental health support in the last month previous to this survey? 1/4 of children in wave 1 and 1 in 5 in wave 2 said, yes, I did need support in the last month. We again asked them, who did you then ask for support from? It was very similar in terms of the pattern of where they were getting the support. But here I want to highlight these 2 categories at the top. The proportion of children who either asked for support and didn't get it, or the ones who didn't ask for support. This was 18% in 2020 in the wave 1. It went up to 27% in the wave 2 of our survey. So there was more than 1 in 4 of the children were not getting the support they need, either because they were not asking for it or because they had asked for it and were not getting it. And that raises concerns about timely access to support for children in care. Children were also really aware of what their support needs were. When we asked them, what do you think should be done to improve your mental health? These are some of the things that they said. And they were very specific about some of them as well. They said, oh, I want support for my anger management. I want support for my self-harm. Or I need someone to talk online anytime I want them to be there. Or they said, oh, my support changed when my schools changed, for example. So they were really aware of what was going on and what they needed in terms of support. And when we looked at children's responses about their support needs, this is what they said. They said that they need specific support for their mental health in a timely manner. They said that connections should be improved with their birth families, and that would make it better for them. So this is about contact. They said their trust in the care system could be improved, and you could link this back to whether they thought whether their life was better when they were in care. Around a third didn't think it was better. So how do we improve their trust in the care system and empower them and give them a sense of control? They also put a lot of emphasis in schools, and this is quite apparent in all throughout these dialogue, because we know for children who are adolescents, these were children who are 11 to 18 years of age, peers, children, friends are really important in their lives. So school is a really important factor, and it's really important that we get it right. Now, this is what children said. Apart from that, we also want to statistically see, looking at everything that was going on in children's lives and their developmental context, what actually impacts the mental health of children. And these are the things that we looked at. We looked at children's characteristics, their placement, their school, social work, friends, and health and well-being. I'll give you about 30 seconds to read them through, because I don't want to just read out a list to you. But these are the things that we looked across the developmental context, and also looking at the relationships across those developmental contexts. And these are all the things that we knew from previous research to be linked to mental health in some way. So first, what we did was, rather than looking at all of these at once and their influence on the mental health, we wanted to see, if we consider each of these, what's the influence of each of these on the mental health of children? Is there a link at all? What's the relationship? Is there a statistical relationship that we can see? And these are the things that came as significant in our analysis. Children who were male had better mental health. Children who were older in our age group, so we had 11 to 18 years of children who as they aged had better mental health, and also children who were of other ethnicities than white had better mental health. The gender and the ethnicity trends are very similar to the general population. However, in the general population, mental health concerns increase as children age during adolescence. But in this group, the mental concerns decreased. And we think that might be linked to the school transition age again, and the turbulence that introduces to these children's lives. And all of these were individually linked to mental health. So being placed with kin was a protective factor. Living with siblings was a protective factor. If they had been in a placement for a long time without having a placement breakdown, that was a protective factor. Having fewer number of placements in care, not running away from your placements, indicates that they're happy in their placements. Whether they had positive feelings about the placement and whether they had a good relationship with the carers, they were all predictive of better mental health. And children who had positive feelings about school, children who were not excluded, those who didn't truant, miss school without permission, and those who had fewer number of school changes linked to their placement changes had better mental health. And those who also thought that they had good teacher support at school had better mental health as well. And in terms of social workers, children who thought they had the best level of contact with their social workers, have positive relationship with them, and also felt involved in the decisions that the social workers were making. All of these were linked to better mental health. In terms of friends, again, friends were really important in terms of the regressions, the models that we were doing. And these children who had positive relationship with friends and who were not bullied had better mental health. Health and lifestyle was also important, whether they had access to a green space, whether they were doing physical activity like exercise, and screen time was an important predictor. where the children who had more screen time had worse mental health. And not having a physical disability, having a hobby was important, and not engaging in risky behaviors such as smoking or drinking. So these were all individually significantly related to children's mental health. But what we were interested in is, if we considered all of these at once in one model, what would then be the most significant factors that predict the mental health if you were to consider all of these at once? So we ran something called a hierarchical regression, where you can put all of these factors at once to see what comes across as significant in predicting the mental health of children in care. And this is what came across as significant in the first wave. Gender, age, ethnicity were all significant. Living with siblings and having a positive relationship with the carers was significant. Not being excluded, positive feelings about school was important. In terms of social work, whether they were satisfied with the level of contact they had with the social worker, and whether they had a positive relationship with the social worker was important. And in terms of friends, the strength of relationship with the friends. And the biggest predictor in terms of health and well-being in this analysis was having less screen time. It was predictive of better mental health. Now here, I want to highlight something. As you can see, we entered in the model everything about the placement, including the number of placements children have had in care and the length of placements. And usually when we do an analysis of children in care and look at the national data, for example, the number of placements come up as the biggest predictor of absolutely everything that we are looking at. But here, because we included relationship variables and familial variables, such as being placed with siblings or being placed with kin, what happened is the impact of these placement variables disappeared. What it shows is, it's not to say that children can have as many placements as possible and it doesn't have an impact. It does. But what it shows is, in terms of children's current mental health, the biggest predictors are children's relationships with the developmental context that they're currently in. So it's really important that children are matched well with the placement that they're currently in, and that they're happy at school, they have friends that they can go out with, they have less screen time, and they have good boundaries for healthy behaviors. This is what came across as significant in the second model. A little bit different to the first one. But when we put both of those things together, this is what came across as significant in predicting the mental health of children in care. So looking at children's developmental context, it's really important that we are aware of some of the characteristics that which we obviously can't change. For example, the fact that female children are much more likely to have significantly more mental health concerns than male children. White children are more likely to have more concerns than children who identify as all other ethnic groups. We should be aware of those risk factors. In terms of placements, as you can see, it is all relationship-based ones that are significant here. Living with kin, living with siblings, having a positive relationship with the carer. Those were the biggest predictors of better mental health. School was really important, having positive feelings about school and not being excluded from school. So in our study, 34% of children in wave 1 and 24% of children in wave 2 said that they had been excluded from school at least once. That's a very high proportion of children being excluded from school. And we can say that it has a really negative impact on the mental health of children. So social work support, being satisfied with the contact frequency and having a positive relationship, not being bullied, having a really good relationship with their friends, spending less time screens, not engaging in risky behaviors such as smoking, drinking, taking drugs are predictive of better mental health. And what is quite nice here is having a hobby was also predictive of better mental health. What does that mean? When there's so much of turbulence in these children's lives, having a hobby could mean that that's something that stays with them constant across time and space. So it's really important that we encourage that as well. So what are the recommendations for policy and practice? We should be embedding mental health screening into the statutory review process, which happens every 6 months for children. It should not only be an annual review that can only to return data to the DFE. It should be a statutory review process, part of the statutory review, so that it can look at the total developmental context of children, rather than only the mental health screening score. It's really important to do that. It's really important that we facilitate timely access to mental health services and that we educate children about how and where they can access the support that they need. As you can see, there were lots of children who needed support in the last month of our survey, previous month to our survey, who were not accessing the support that they required. Familial connections are really important. Placing with siblings is really important. Around 92%, I think, of our survey sample had siblings. I think less than half were placed with a sibling in our surveys. That's really low in terms of the placement with siblings. It's really important to facilitate nurturing relationship with the carers. Now we understand that some of these placements happen during emergencies, they need urgent placements, but if children are to stay in long-term care, and if that's the decision that's being made for these children, it's really important to ensure that children are matched well with the carers that they're going to stay on for a long period with. We also think that we should extend the responsibilities of the virtual school heads. It's a strategic role which looks at educational outcomes. It also looks at well-being in a broader sense, but they do not track individual children in the local authorities. We do feel that there should be a responsibility placed on someone to track individual children's mental health. It's really important that we support children during school transitions, especially from primary to secondary. Now, children in care in England have priority access to schools. One question is, are they involved in this decision-making at all? Who is making the decision for these children as the schools are chosen for them as a secondary school? I think they should be involved in this so they can think about who their friends are and whether their friends are also going with them, for example. We should think about minimizing school exclusions for children in care. The proportion of children who are impacted are really high, and we should be thinking about substitute ways of addressing these school exclusions. We should stabilize and strengthen the social work support. The social work turnover was 16% last year, and there were 18% of the social work workforce was agency staff. How can then children have strong, stable relationship with social workers across time, which is a significant predictor of better mental health? So it's really important that we stabilize this churn in the social work workforce. We should promote healthy behaviors. We should be giving more health messages to children about smoking, about drinking, about drugs, about having less screen time. That it should be it should be given to the children in a way that is really promoting healthy behaviors. We should facilitate children's interests and hobbies across time because that is a protective factor amongst the churn that these children face across time. We should facilitate their peer relationships as much as possible, healthy peer relationships, address bullying where possible. And also we think something that was tested, but it was not rolled out to every local authority. It would be quite good to have a virtual mental health lead in every local authority who is in charge of the mental health of children, because mental health is something that predicts lots of future outcomes for children in care. And if we can get that right, I think lots of things will fall into place. Thank you very much. I think that's 45 minutes. That's good.